Good afternoon, everyone. We're going to go ahead and get started. My name is Denise Marte. I am a project specialist at the Rhode Island Department of Health and the Health Equity Institute that you'll be hearing a little bit more about today. We're excited to have you here for this discussion. This presentation is entitled Addressing Place as a Social Determinant for Mothers and Children, MCH and Rhode Island's Health Equity Zones. It is session ID H1. It is also accredited for continuing education. A continuing ed information sheet can be found at the registration desk, on the conference website, and in the conference app. We ask you to please silence or turn off any cell phones or other mobile devices. And now it's my pleasure to introduce our two presenters. So Deborah Garneau is currently the director of the Health Equity Institute and the Title V Maternal and Child Health and the Special Needs Director for the Rhode Island Department of Health. So she wears many hats, so it'll be easy to see how a lot of this comes together in what we do. And our other presenter is Ms. Jamie Camella, who is the Rhode Island Department of Health Maternal and Child Health Program Manager and Title V Coordinator. So please welcome our speakers.
All right, great. Thank you, everyone. So we at the Rhode Island Department of Health, I'll just say two quick things about where our maternal and child health program is located. So we sit within the director's office, and within that office we have maternal and child health, we have the prevention block grant and its roles and responsibilities. We have our disability and health program, and when we also have our Office of Minority Health, which includes refugee health and some minority youth violence prevention programs. So, so we formed the Health Equity Institute, and again, our program, our institute sits right within the Director of Health's office. So a lot of our maternal and child health programs, the implementation of the programs, might be sitting in other places, so newborn screening, immunization, WIC programs, they're not necessarily in our office, that we do the policy and managing the overall function of maternal and child health within our office. So a couple of years ago, when we had a new health director at the health department, Dr. Nicole Alexander Scott, we went through a process as the department's leadership team where we looked at how well we were doing with our health outcomes. And we were looking at the various initiatives that we're working on, and we were able to take kind of a fresh look at some of our programming and the practices in which we were working towards. So when I put this slide up, a lot of people who are epidemiologists and data folks kind of get nervous and say, oh, where'd you draw these conclusions from? But what we did was really take that 30,000-foot view and looked critically at our programs. And what we wanted to see is that, are we on the right track? Are we making improvements in some areas? Are we, is there any change in the data? Are we realizing the results we want to realize from the work that we're doing, continuing, in the same vein of how we were working. So we saw that we were making a few improvements. Certainly our tobacco rates had come down in our state. We were making some improvements in our violence and injury areas. We had some areas where we didn't have much change. We didn't really have much of an impact in our physical activity and our kids and adults being active within our state. We saw some negative impacts in our overweight and obesity and in our mental health and substance use, that we were really going in the wrong direction. And then we had some other areas where we were mixed. I'm not sure we're having much of a great impact one year, and then the next year it would dip down, and so some of the results were very mixed. Even in the areas where we had improvements and we were doing well, like the tobacco, for instance, we had significant disparities within our tobacco rates. So in the health department, we were celebrating our low smoking rates, but when you looked further at it, we realized that people with disabilities were smoking almost twice as much. Those with less education and those with less income had these large disparities in these areas. So we really did this connecting with our work differently and trying to understand how we could start to address, and we were trying to figure out, like, where are we going wrong with some of these work and some of this flow of how we were continuing our work. We looked at some of the national data, international data. We looked at what seems to be making differences and some changes. We looked at, if you look at life expectancy as the ultimate health outcome, then we noticed that we were spending a lot of money on our health care, but we were not getting the same results as other nations. We also were looking at the investments in our social services and then the investments in our clinical and medical care. And we can see that it's way out of whack, that we're spending lots of money within our healthcare system itself compared to other countries who spend a lot less in their medical health care and have more of the supportive social services that are available. And we also looked and were very compelled by the information around the social determinants of health and where the health of a person actually comes from. We saw a slide about this earlier today in this morning's plenary. My percentages might be a little bit different. I think that we've combined the clinical care and the genes and biology for what the other presenter had spoken about earlier. But really looking at the social and economic factors and then also the resulting health behaviors that we can see really as a factor of where people are living, working, and growing, and trying to get at where these determinants of health come from. So what we know from many of these slides together is that if we're looking at the clinical care, which contributes about 10% of what makes someone healthy, and then we look at all of the expenditures on this slide, all of these blue line expenditures are really going towards that 10% of the clinical care. And so this was very compelling for our leadership team, and we actually made lots of significant changes as a result of this analysis, and our leadership encouraged us to do our work differently and to really change our focus. Rhode Island joined, just like some of other states in the nation have joined with the 100 Million Healthier Lives initiative. There's a cohort of 13 states that are focusing in this area, and we're sharing best practices around health and population health and doing our work differently and really getting at that 80%. And so I really like this slide because it sums up a lot of this hard work that we did in kind of a nice picture. So if you go through 1, 2, and 3, it's really a lot of that framework that I just spoke about, which is that, we all in MCH don't need to be convinced that we need to take a life course perspective. The second area is really getting at, we need to address the social environmental determinants and economic determinants of health, and not, really focus on the medical care. Number 3 is like a real great focus area, and our initiative that we're going to speak about today, our health equity zones, really helped contribute to number 3 being on their slide because place is really important. Number 4s and 5 are really looking at the healthcare system itself, and so the healthcare system needs to identify and to address some of the key demographics. And then also that the healthcare system needs to support and financially contribute to models that have this greater value. And then number 6 is awesome, especially when we speak to our community-based organizations, because they're saying, don't duplicate it. We've been doing housing, we've been doing autism coordination, we've been doing connections with transportation, all of these things. Like, we're not asking you hospitals or healthcare systems to start working in those areas. We want you to pay for us who are already doing that and successfully doing it. We know how to, we can identify with the community, we have this level of expertise. And so number 6 is like this recognition to say, support those who are actually doing this work rather than replicate it yourselves. So our health department kind of has gone through this progression of making these changes, looking very critically at the work that we're doing. We've developed these as a leadership team within the health department, developed these leading priorities. And so these need to go across all of the departments. So our Office of Medical Examiner and our state laboratories and our facilities and licensing, all of the components that we manage throughout the health department need to address these 3 priority areas. And the 2 support systems here is the Health Equity Institute, which is where the MCH program lives, and then also the Academic Center, which really helps us to connect better with our institutes within Rhode Island, our academic institutions. So here, this is just the vision of our health equity in Rhode Island, and we borrow these definitions from others and really pull together different pieces of definitions that we liked. And so, there's a real acknowledgement of the root causes and needing to address and make corrections for those root causes. So one of the things that we wanted to look at in our state and in others is really what would health equity look like at a community level. We borrowed this, we took this model and this envisioning from the adverse community experience and resilience, which takes the ACEs, which is, we heard a lot about this morning, it takes that at an individual level and then it expands it and applies it at the community level. So just like adverse childhood experiences makes impacts on brain development, also adverse community experiences and being constantly surrounded by these adverse community experiences, it has impacts on the functioning of the people, and it has impacts on the functioning of that community. And so, all of these particular components coming together where we're looking at the people, the equitable opportunities that are available, and also the place, having these impacts on the particular community. So we were applying this model along with a lot of the work that we had been hearing and understanding around how important place is and how there's this real interplay between where someone lives, works, and plays and their health outcome, and looking at establishing a zonal or a community-based initiative, and that we call the health equity zones in Rhode Island. So some of, again, getting back to some of the breaking down some of the ACER framework, there's the individual approaches, and I think we're all pretty familiar with a lot of the individual approaches within MCH. Looking at individual trauma care and, how much education the individual has, the financial literacy, looking at the distinct programs that we might be providing around family visiting, et cetera. And then looking at some of the community strategies and again, thinking of like how we can make changes at the, not just at the individual level, but then also at this larger So in Rhode Island, again, we have the health equity zones. We established them 5 years ago. We put out an RFP within our state, and we asked communities to identify their geographic location. We asked them to form a community collaborative and then to assess their needs within their community and to prioritize those needs. Currently we have 9 health equity zones, so this is our small state of Rhode Island. We have one of our health equity zones is the whole lower green area. That is our South County area, and that's right along the ocean, and those are our South County communities. And then we have several other pockets of health equity zones. We have our capital city of Providence. We have 3 health equity zones within that Providence area. So the goal again is for them to be to develop this collaborative process and to really figure out how they're going to make decisions within this community collaboration. So I think I had already said all of these. One of them that I didn't specify was around the collective impact framework. So we've connected a lot with our City Match colleagues and others around assessing for collective impact and really training folks on collective impact and what that might look like. Another key component was looking at sustainability and how we can coordinate the evaluation and the continued improvement of sustaining these initiatives. And then one other thing I'll say about our health equity zones. So sometimes folks will ask, who are the members of the collaboratives? And so some of them are MCH partners. We have our healthcare centers that might be functioning within that zonal area, community health workers. We have our federally qualified health centers, faith-based leaders that are part of the collaboratives as well, and a lot of the community-based organizations that work with like housing or access to food and nutrition within that community. There's a lot of municipal leaders that are parts of their health equity zone and their collaboratives as well. So the long-term goals of the HES is to improve the health of the residents, to really address some of those adverse community experiences that we talked about earlier and saw earlier, and then to improve birth outcomes, to reduce disparities, and really to address those social environmental conditions that are preventing the residents in that particular area from being healthy. Oops. Is this the video? Okay. We want to show a video.
With health equity zones, the Rhode Island Department of Health, and all across Rhode Island, we believe strongly that everyone deserves the opportunity to live a healthy life regardless of their zip code. The health equity zones is not just a project, it's really a movement. We know we have socioeconomic and environmental conditions that need to be addressed. We know about the disparities, we know about the numbers that exist. Health equity zones gives us an opportunity to go from talking about those numbers to putting an infrastructure in place that puts the community's voice front and center and gives us the opportunity to do something about those numbers.
Particularly in communities here like Olneyville, where we're part of the HES, we know that living in poverty is a toxic stressor which can negatively impact brain development. We know that with a mindfulness program as part of social and emotional learning, we can teach some healthy coping strategies for success in school and life.
The impact is seen daily. We have a walking school bus. If you live less than a mile away, 0.9, 0.8, you have to walk to school on your own. When you're 5, 6, 7 years old, it can be a little scary. The walking school bus ushers them to school safely and brings them home safely.
Thank you. Oh, yeah. 120. The great thing about Sankofa World Market actually is, especially in the West End and the South Side community, there's not a lot of like grocery stores that provide these fresh foods. So the goal of the market is to have the chance to provide fresh produce, and we also provide a lot of nutrition to those in the community that may not have access to it.
Hi, my name's Alicia and I went through the Youth Police Initiative. It was important because I felt like I was more safe in Providence now that I got to understand where the police were coming from, and I feel like the police got to understand where we were coming from. Yes, I see them patrolling around and they always wave to me.
It's important to have healthy, clean, quality, affordable housing, because if people don't have a home to go to and they don't have a place where they can focus in, they can't thrive. They can't perform at work, they can't perform at school, they can't think about progress because they're too busy surviving. We've addressed the housing by forming Neighbors for Revitalization, bringing community members out to get engaged in their lives, in the course of their lives, and what happens with housing in their neighborhoods.
I really appreciate the work of our heads groups. I think that as a mayor, their voices really help instill the fact that there are many concerns that sometimes we don't see, that we might overlook, and one of them is their health. And I think that this ordinance will help control the runoff by planting more trees. It will help clean the air, and more importantly, for those
With health equity zones, the Rhode Island Department of Health, and all across Rhode Island, we believe strongly that everyone deserves the opportunity to live a healthy life, regardless.
So you have the idea of the video, and there was a couple more minutes that really went through some of the other outcomes, but we can make it available. It already is available as part of our slides. So the funding for the health equity zones, it's a real comprehensive program, and so it's not like we get money from the federal government or from a private foundation that says we want you to do your work differently. We want to fund these social determinants of health work, and so we take our categorical funding that we get at the health department and we pull pieces of it in order to fund this larger community initiative. And so we have had funding from oral health. Certainly we have the maternal and child health block grant, and we have another CDC prevention block grant that we use. We do have some state minority health funding that we utilize as well for this program. And then we have some pockets of funding that we flow initiatives through. So if a community has a high rate of diabetes in their community and they want to run through their health equity zone, if they want to start to address diabetes, then we go to our chronic disease diabetes program and we ask them for funding and to support the health equity zone or to utilize the health equity zone to advance their priorities. And so we do that with all of these different programs here in our department. So I'm not, this is you, right? Okay.
So now we just briefly wanted to talk a little bit about how the Title V block grant directly supports the health equity zones in Rhode Island. And this paragraph was taken directly from the HRSA website. And the key here is that it states that the states have the flexibility in how title funds are used to support a wide range of activities that address state and national needs. And during our block grant review last year, Ellen Volpe, who was our project officer and the chief of the eastern section of AMCHP, said to us, and this was really reassuring to the work, that Rhode Island is taking the essence of the block grant and giving that flexibility to the community, and that's really how we see our role. So the work of the health equity zones primarily falls within our cross-cutting life course domain. However, as you can see from this matrix, it does align with many of our Title V priority areas. And so this is really just a schematic of what that looks like in actuality. And what we did as a program, as a Title IV program, was provided guidance to all of the health equity zones on what our 10 priority areas were. And they, based on their needs assessment, decided to work on different priority areas within that plan. So, you know, regardless, the other important thing here is that regardless of whether or not they're using our Title V funds, we continue to provide technical assistance from the Department of Health. And what that looks like is primarily 3 different big buckets. One is we have a project officer who is assigned from the Department of Health to work very collaboratively with each health equity zone. They attend all of their collaborative meetings. They are in communication with them on a regular basis via email, and they act as a conduit to help the health equity zones who may not have subject matter expertise connect with people at the Department of Health. So for instance, if a health equity zone is working on childhood obesity, they would connect them with the physical activity and nutrition program. Another way we provide technical assistance is by holding quarterly technical assistance meetings. So we invite all of the heads to come together, and we set the agenda each quarter based on some needs that have bubbled up, but also things that are important to the Title V program and other programs at the Department of Health. And lastly, we really we work with them really to address their technical assistance needs on in real time. So when anything comes to the forefront, they reach out to us, and we make sure that they have the support that they need. So we wanted to provide some real-life examples of what they're doing. This slide is showing some of the work that the Family Visiting Program has done with the HES. They're working in several different communities, and they're providing, they're really making an effort to be part of their collaborative meetings and make sure that all of those agencies that are sitting on the collaboratives are aware of the opportunities and the services that Family Visiting provides. So they're extending their reach within the community and reaching young families earlier so that they can roll in family visiting services. They're also, I'll just move to the next slide. In the Oneyville HES, which is located in Providence, we have a health equity zone, as you saw in the video briefly, who has created a walking school bus. And they have 30 participants who are participating in 2 routes. They walk an average of about 1.5 miles each day, and for a total of 300 miles over the year. And this has been really instrumental in helping the kids work on their physical activity, but also has been addressing safety concerns in the community, as well as school attendance rates. And this elementary school in particular has now been able to say that they have achieved the highest attendance rate in the school. This has also been able to work with some local nonprofit agencies to offer 8-week bike camps for youth in the community, as well as free April vacation sports camps for youth who are interested in basketball, football, soccer, and biking. And lastly, this Oneyville has created a baby love hub, which conducted outreach and promotional activities to engage the Oneyville women in creating breastfeeding support services. And really where the collaborative has been instrumental is creating relationships. So for instance, the Baby Love Hub is hosted for free in one of the other collaborative members' spaces, which is a local free clinic. The Title V program has also supported the creation of a community baby shower in the Newport HES. And this community baby shower was planned by a resident of the community who has since become a community health worker who specializes in maternal and child health. And this event has given the families an opportunity to receive maternal and child health services related to safe sleep, literacy, healthy eating, dental care, and much more. And the resident really did a fantastic job on making sure that she was including all of the different services of the collaborative members, as well as inviting program staff from the Department of Health, including the tobacco cessation program, as well as the coordinator for the Safe Sleep program. We have a HES that is also working on childhood lead prevention, and this, by working with the city and the community partners to implement policies to improve the enforcement of lead safety laws in Pawtucket, the Pawtucket and Central Falls has contributed to a 44% decrease in childhood lead poisoning and the certification of approximately 200 lead-safe rental units. So this is the 4th year of the HES doing this work, and we're seeing some really, really positive outcomes. As you can see from this slide, and it's dependent on community, there was a 44% reduction in childhood lead poisoning, a 24% reduction in teen pregnancy, a 13% reduction in feelings of loneliness, a 5 to 7% reduction in body weight for those enrolled in diabetes prevention programs, a 40% increase in the redemption of SNAP benefits, or of SNAP at farmers markets, a 36% increase in access to fruits and vegetables, a 250% increase in community engagement. And what we mean by that is the HES really did a fantastic job of inviting new collaborative members each year. In West Warwick, 46 opioid users were diverted from the criminal justice system, and there were over 1,000 graduates of the chronic disease self-management workshops. So this work has really been proving to be a really promising and pivotal to pushing the needle on a variety of issues. So much so that our sister agencies in the state are really taking an interest in the work that we're doing. And it includes our local child welfare agency, our health insurance agency, as well as our behavioral health agency, who are now starting to invest some of their money into the HES and into this model. So it hasn't come without its challenges. The two big ones for us are local infrastructure and categorical funding. And local infrastructure, I mean that each of these HES collaboratives, backbone agency, really came to us with different amounts of readiness, capacity, and capabilities to do the work. And by that we mean like some were very small nonprofits and other were larger agencies such as the City of Providence. So really had different experiences with managing grants, both fiscally and administratively, and then also had different levels of expertise around some of the program work that was being done. So we've had to think very creatively and systematically about how we engage them in technical assistance and support. And then the other major challenge has been, as Deb mentioned, we use categorical funding and braid that to get this work done. But traditional federal dollars really have not traditionally supported infrastructure, and that is so important to the work that is being done, because you have to have fund the backbone agency to hold the meetings, to do the administration, and make sure that they're reaching out to their community partners. So we really need to think about how we do this and make funds more available. As a Department of Health, we are trying to reach out to foundations and, like we said, we're reaching out to our sister agencies, but it would be great if our federal partners could also invest in this type of work as well. And so that's where I'll end, and I'll just pass it back to Deb to really round this discussion out and then take some questions.
Okay, so we've talked bits about the ACER model and the framework, and this is kind of just seeing it all together. So the traditional public health, the traditional approaches that we might be having in communities and elsewhere is really looking at the individual approaches, and then looking at, we get certain outcomes when we do individual approaches, and then looking at the larger community strategies and, and really looking at seeing how we can address more of the community strategies and the work that we're doing. And so, getting those community resilient outcomes that we're most interested in to really address that social environmental determinants of health so that we can get the outcomes that we're interested in getting. And then I'll just wrap up by saying that now is a nice time to start to work on such initiatives. If your state is looking to address things differently, we have the opportunity with the needs assessment. I've heard lots of conversation here the last couple days about really getting at the heart and the root causes of some of the work that we're doing, and not just doing it these categorical programs that are not getting us the results that we want. And also our health director, whom you saw in the video, Dr. Nicole Alexander Scott, she's actually the president right now of the ASTHO, the Association of State and Territorial Health Officials. And this is her challenge, and they have connected with NACCHO and the U.S. Surgeon General on really addressing these place-based initiatives and getting the results, doing the work differently. There's a lot of energy and a lot of momentum in this particular area. And the President's Opportunity Zones and that funding is really asking businesses and others to take their profits and to invest in communities. And, all of these are coming together at a time when it's great to start these health initiatives. So we have our information. Certainly the longer video is in the slides that you have access to. But are there any questions that we can take now? Please. Hi.
Hi, Mandy from Colorado. This is really exciting, so thank you. One of my questions is kind of the distribution of funds. So knowing that you guys blended and braided, is it a portion of each of those different federal grants that's going towards this, or did you have to convince like all the chronic disease folks to agree to go along with this bigger initiative, or they say like, we'll give you 15% of our grant to go towards your health equity idea?
Right. So we have a Jamie was gracious when she said this is a challenge because we've had a lot of challenges with our funding. We used the kickoff money for the health equity zones from the Integrated Chronic Disease 1305, 1422. Anyone who knows those fundings knows that they started out by saying we want to address social determinants of health, 50% of this money needs to go to the community, on and on and on with this very loose criteria. And then a little bit into the grant, they said, oh no, we want diabetes, we want cardiovascular disease. And, they were very stringent about how that funding was being spent. And so we had to retract a lot of funding from the health equity zones who weren't necessarily working. We tried as much as possible behind the scenes to say, okay, you're working on physical activity and nutrition that fits this criteria. You're food access. We had a lot of programs doing food on the move, farmers markets, lots of getting food into particular areas. We tried to tailor, that money behind the scenes. We have since changed our funding structure for health equity zones. We currently have an RFP out for new health equity zones, and what we're doing now is we're going to pay for infrastructure with the more flexible funding, which is MCH Prevention Block Grant and some of our state money. And then we're going to ask the health equity zones to apply for, or to, based on their needs assessment, to that will work behind the scenes to identify either breastfeeding money or, chronic disease money or whatever it might be. So that is kind of our new model of how we're doing the funding. So it's a fiscal challenge.
Can I ask one other question quick while you have, are you guys measuring, like through MCH Block Grant, do you have measures for some of this work that are not just your priorities? Do you have like SDOH type measures that you've identified?
Yes, we've actually, it falls, as Jamie mentioned, it falls under our cross-cutting for the MCH work. And so we've counted up the number of activities that we have, maternal and child health activities that are happening through the HES. We have looked at like longer term, like access kinds of things, access to health insurance, access to some of our other priorities, and we put them in as ESMs. We are looking forward to, really revamping that and to getting at some, really assessing like those social determinants of health, which is a challenge for our field right now. But we're, working with Kay Johnson, like really trying to identify some of those areas that we can get at.
Hi. My question is, so if you talk about equity, and we know that racial inequities are the greatest inequities that we're facing as a country, and I'm assuming in Rhode Island as well, are you doing anything to specifically address racism and racialized outcomes in health?
What was the question about racial equity?
Yeah, in your work, are you doing anything to directly address racism and to promote racial equity in your work, knowing that racism is kind of the underlying cause for all of the racialized outcomes that we see?
Yes. So yes, we have. And we have, as Jamie was mentioning, lots of the learning communities, the technical assistance work that we provide to the communities. We have been talking about all the different isms and certainly racism. And we've done implicit bias training and certainly raising awareness. We have one particular health equity zone that is really looking at the power differential in their community, and they're aggressively addressing some of the power difference between, they have like a real strong hospital, and then they have like this whole community group that feels disconnected, and a lot of that is integrated in the racial politics of the community. And we have some wonderful stories about a community health, or a person who was hired by the health equity zone to do needs assessment. And she went door to door and was asking what are people's needs in the community. Then she became a community health worker hired and trained by the health equity zone. And then she became, ran for and was appointed to a zoning board within the community. And then she ran for a statewide office representing that community. So we have this progression of, this one woman that just kind of went through these 4 years of our program and gaining in her power and being able to address some of the institutions that have been set up in that community. And so, yes, we have lots of examples of that. Certainly within our healthcare system, that's part of the health equity zones. We've done a lot of work in addressing the racial disparities. And, really helping the community leaders even understand what that is, and helping them to be more in tune with the data from their community. So.
You mentioned that, when the challenges, that the local infrastructure was something that you're trying to build or look at for building capacity, and I was just curious about what kind of infrastructure you needed to get this off the ground. So you mentioned a backbone agency. Did you have one? Are they acting as the fiduciary agent and getting a mini grant process out, or do you have contracts between the Department of Health and these entities that apply for these zones? I was just curious to see how it kind of works.
Yep. So we issued an RFP. We selected the backbone agency with a collaborative, and so the commitment to, and we provided guidance to them, like, no, you need to expand this collaborative. This isn't diverse enough. You need to include, whoever from your community. But the health department contracts directly with the backbone agency, and they distribute funding throughout their community. And, some of them are supporting initiatives with their parks and recs, so they're municipal agencies. Some of them are supporting some of their housing initiatives within their particular area, or a youth movement, or, there might be different groups. But we have that contract directly with a backbone agency, and then they administer the health equity zone within their zone. And so that does require them to have a certain amount of, fiduciary. They need to be able to front some of the salaries, and we're paying them on a reimbursement basis. So we did have a challenge with a small agency that just, there was an influx of like $250,000 into their agency, which required staff and them to do a lot of, record keeping and things that they weren't familiar with, and they actually sent back the money and said, we can't do it. We don't have that kind of capacity.
And then does that backbone agency provide training in TA, or is that through the department? And then I'm just, again, I'm so curious. And then evaluation and QI, like who does the data tracking and all that stuff?
Okay, so we do a lot of the communications, a lot of the evaluation centrally, and the, there was one other piece that you said. Yes, the TA. We do that at the health department. By hearing from the community of what is needed, and then we organize it. We get the experts in, we organize that piece of it. And, but some of the health equity zones have some of their, they use some of their dollars as well to understand the impacts of their programs, and then to also, market and produce some of the communication materials internally. We have we did ask, we have the evaluation on a couple levels. One of them is looking at more of the equity indicators, and those the health department does. The ones that are evaluation, like, one health equity zone implemented this breastfeeding program, and their evaluation measures for that breastfeeding program, we ask them to do those evaluations. And then the larger pieces of like community engagement and, civic mobilization and, the larger things around there, breastfeeding rates and teen pregnancy rates, like we can do all that at the department level. So we don't necessarily ask them to keep that data. Okay, anything else? All right, well, thank you for your attention.